Bismillahirrahmanirrahim. So today we are going to study about the class 2 antiarrhythmic drugs. And the class 2 antiarrhythmic drugs are called the beta blockers. But before studying or watching this lecture, you must know about the class 1 antiarrhythmic drugs, the class 1A, class 1B, class 1C, and the mechanism that how the arrhythmia develops and the normal cardiac action potential. We must know the lecture before, so in order to understand this such kind of lecture you must watch the other lectures. So kindly watch the other lectures. So before starting the beta blockers, we must know that what these beta blockers do. They mainly terminate the action of adrenergic stimulation, and this adrenergic stimulation is due to the release of catecholamines. So what are the action of adrenergic stimulation on the heart or other body tissues so related to the arrhythmia? So first of all, it causes decrease in the potassium level, i.e. hypokalemia, and this hypokalemia, as we already know, that this hypokalemia can lead to serious arrhythmia. The second effect is on the SA node, and this effect is in the form of increase in the pacemaker current, which is also known as the funny current. And if this funny current, as we have already discussed, that cardiac action potential, this is the pacepore depolarization, and this pacepore depolarization, this current is known as the funny current. So increasing this current can increase the pacepore depolarization, which will in turn increase the heart rate, and this increase in heart rate can lead to the arrhythmia, cardiac arrhythmia. The third action is on the AB node, and this is in the form of the increased calcium and potassium currents. And we know that the calcium current in the automatic cells of the heart cause the conduction velocity. This is due to the calcium, and if this current is increased, calcium current increase, the conduction velocity or the phase zero depolarization will increase, and this phase zero depolarization, increase in phase zero depolarization can increase in the conduction velocity. So there will be the increase in the conduction velocity, and this conduction velocity can lead to the arrhythmia like re-entry arrhythmia. The fourth effect on the cardiac cells is the increase in the calcium ion stored in the endoplasmic reticulum. As we have already discussed, that the calcium current causes the increase in the delayed after depolarization or the early after depolarization mediated arrhythmia. So increasing the calcium current can cause such kind of arrhythmia. So now coming towards the effects of beta blockers on such kind of tissue. So first of all, the beta blocker will decrease the pacepore current. They will decrease if we block such kind of adrenergic stimulation, so these kinds of effects will not occur. And if these kind of effects will not occur, so the chance of arrhythmia will decrease. So coming towards the effects of beta blockers. First of all, beta blocker, it will decrease the pacemaker current, which will decrease the pacepore depolarization, and this will cause decrease in the heart rate, and thus decreasing the chance of or decreasing the arrhythmia. The second effect is by blocking the potassium channels, and this blocking will increase the refractory period of the heart muscle, which will in turn decrease the conduction velocity, and this conduction velocity is mainly in the AV node. As we have already discussed, that decreasing the conduction velocity will prevent the chances of arrhythmia or can decreases the arrhythmia. The third effect is in the form of preventing or blocking calcium current, and this will directly cause the decrease in the delayed after depolarization or early after depolarization mediated arrhythmia. So these are some kind of arrhythmias which we can prevent by giving the beta blockers. Now the beta blocker, as we will discuss in the classification of beta blocker, that is mainly divided into first generation, second generation, and the third generation. So the first generation, for example, propranolol, which are the non-selective for the beta 1 and beta 2. I will change the color. These are non-selective for the beta 1 and beta 2 receptors, and they are mostly used for the catecholamine induced tachyarrhythmia, like the exercise induced or the stress induced, in which the catecholamines level in the blood increases, and these first generation beta blockers like propranolol are mainly used for such kind of tachyarrhythmia. Now coming towards the second. Now the second example is sutalol. It is also a first generation beta blocker, but it consists of two isomers, the D isomer and the L isomer. Both the D and L isomer have the same potassium blocking activity, i.e. the class 3. It can act as a class 3 antiarrhythmic drug. This we will discuss in the class 3 antiarrhythmic drug also. But the L isomer mainly has the much more increased beta blocking activity. So we mainly use the L isomer of the sutalol. As we discussed, there is additional potassium channel blocking activity, which will increase the effective refractory period. It is mainly used to treat the life-threatening ventricular tachyarrhythmia. Sutalol, mainly the L isomer of sutalol, is used to treat the life-threatening ventricular arrhythmia, and it is also used to maintain the normal sinus rhythm after the atrial fibrillation or atrial flutter or atrial tachyarrhythmia. Now coming towards the second generation drugs, which are mainly beta 1 selective, and the example is esmolol. And this IV esmolol is mainly used for the emergency control of ventricular rate in the atrial flutter. In the atrial flutter, it is mainly used for the emergency control of ventricular rate in the atrial flutter. The third generation, which have additional vasodilating activity, can also be used for the antiarrhythmic action. So now coming towards the uses of beta blockers. So the first use is it is used to terminate or prevent, I will change the color, terminate or prevent the tachycardia in which the AV node is involved, which is known as the AV nodal reentrant tachycardia, SA nodal reentrant tachycardia, and the macroentrant or bypass tract mediated tachycardia. So these are as the re-entry mediated tachyarrhythmia or arrhythmia in which the AV node is involved, SA node is involved, or the bypass tract is involved. So the beta blockers can be used against such kinds of re-entrant arrhythmia, and they act by depressing the re-entry pathway directly. And thus can help terminate the related tachyarrhythmia. The second use is this can use to slow the ventricular response in the atrial tachycardia, which may be automatic or re-entrant, atrial fibrillation, and the atrial flutter. It is used to slow the ventricular response of ventricle to the atrial tachycardia, atrial fibrillation, atrial flutter, and it is mainly due to the increase in the refractory period of the SA node by the beta blockers due to the potassium channel blocking activity, and this will allow the less or fewer impulses to pass to the ventricle, and thus slowing the response of ventricles to the atrial tachyarrhythmia. So now coming towards the adverse effects, so they are same as we will discuss in the ANS. So kindly refer to the beta blockers ANS for the adverse effects.